And thanks for everyone who's joining us. My name is Emily Bucholz. I'm one of the associate editors for JACC. I'm a pediatric cardiologist at Children's Hospital Colorado. I'm here this morning with Anne-Marie Valente, who is another associate editor for JACC, and she is heads up the ACHD program at Boston Children's Hospital, and contributed to this editorial with Dr. Carole A that we're going to be discussing today. Thanks for taking the time to chat today, Anne-Marie. I really enjoyed reading the editorial that you and Dr. Carole Warrens wrote about the new ACHD guidelines. I think it really helped put the new guidelines into perspective, particularly relative to the 2008 guidelines. As you were kind of looking back and comparing the two sets of guidelines, what do you see as this kind of single most transformative change in ACHD care that was kind of reflected in the updated recommendations?
Well, thank you so much, Dr. Bucholz, for having me. And I really was excited to do this with Dr. Warrens, who brings such a wealth of experience and knowledge. And she was on the cutting edge when she was leading the guidelines back in 2008. And I think what we recognized is the guidelines have come a long way with the amount of evidence that we're able to use to base some of the decisions on. And yet, there's still so much more to do and so much more evidence that needs to come to light. And that I think the biggest change has been just really thinking about the partnerships that we need to develop between the clinicians for ACHD to flourish. And that is that the ACHD cardiologist is partnering with the primary caregiver for the patients to make sure that the best care is delivered.
That's excellent. That actually leads me kind of right into my next question. What the guidelines very strongly emphasize that all ACHD patients, kind of regardless of complexity, which was a big change, should have at least one evaluation by an ACHD cardiologist. What was the evidence that you saw that kind of most convinced you that this should be a class 1 recommendation?
Yes, that recommendation is new, and it really is based on some cohort evidence that patients who are not in specialized care with congenital heart disease do not have as optimal outcomes. And yet, I think the other point that Dr. Warrens also emphasizes is that, even the most simplest heart disease is not always that simple. And if you think about atrial septal defects, and people feel like, well, I had a hole in my heart, but it was closed. But the downstream effects on the pulmonary vasculature, the potential to have residual defects or valve disease, certainly there's some genetic influences that go along with that too. So even if you were born with an ASD, had it closed when you were little, thinking about further family planning, there may be a genetic association that you are not aware of, and just partnering with an ACHD clinician to ensure that at least the data that we know can be shared, I think is going to be very helpful in the long term.
Do you still see a role for the kind of the anatomic physiologic, the AP class, and kind of determining who can be safely co-managed locally versus who should be anchored to an ACHD program for their primary care?
I definitely do. And I think the last iteration of the guidelines where the AP class was introduced was new. And that was really based on some of the valvular heart disease guidelines and heart failure guidelines, where we're thinking about stages and not just the primary anatomy, but the other factors that go into the physiologic effects of how people live with their conditions. And you'll see in this newer set of guidelines that has actually been revised. And some of the revisions were based on now using that classification system, what seems to work, what doesn't. There have been several studies published on prognostic value of those, but thinking about the difference between one patient that may live with tetralogy who's been repaired, who has really good functional capacity, no arrhythmias, very little hemodynamic consequences from that, or others who throughout their lives have been plagued with multiple interventions, arrhythmias, some degree of heart failure, not to mention the other multi-organ effects that can come with that. So we really do find that useful.
That's excellent. The other obvious big piece to this puzzle in terms of getting patients to follow up with their ACHD cardiologist is actually the transition from pediatric to adult care. And that obviously remains a major vulnerability. Many patients are still lost to follow up. From your perspective, what practical strategies or system level changes are kind of most urgently needed to close that gap?
Yeah, it's a great question about transition. I mean, we've thought about it for a long time, and so many programs have tried to do different types of transition programs. And I think at least what I've learned is that there's not one size that fits all. I mean, now that the electronic medical record has certain automated parts to it that allow us to designate this person should be going through a transition in their care at some point, that's helpful, but it's not absolute. A lot still falls to the patients and the family. I think the guidelines try to emphasize the more that there can be a structure in place at the individual centers to really help that to happen. So whether that's formal transition at a certain age with educational documents, with nursing navigator or other type of support, or something written down that then encourages that to take place is helpful, because we know from the evidence that is out there that the more that something is actually written down formally in the chart now, the better chance it is that that'll happen. But it's very dependent on the individual geography. There are still large areas of this country where there just are not enough ACHD providers, and patients have to travel a long way to see their ACHD specialists. So I think the more that we get better with the electronic record and our ability to do telemedicine, the more that we're able to work together in ways where we don't have to physically always be together, it's going to just enhance that transition process for patients.
I'm going to switch gears a little bit and talk a little bit about some of the other recommendations. Heart failure remains the dominant final pathway for many CHD patients, but obviously randomized control trials are quite scarce in terms of understanding what GDMT and other types of interventions could look like. How should clinicians balance, extrapolated data, expert consensus, individualized anatomy, kind of more personalized medicine when making high stakes decisions like ICD placement or transplant referrals?
So recognizing that our patients are getting older and that heart failure is a common pathway for many of them, it really comes down to trying to be more timely than just reactive. So if we wait for symptoms, we know, and again, Dr. Warren's taught us this a long time ago, symptoms happen way late into a patient's course of their disease, that we have to work with them to recognize areas of opportunity where maybe starting a medication before they feel badly or before the ejection fraction drops, or maybe thinking about more advanced electrophysiologic issues that could help them with regard to their exercise tolerance. Those are the critical issues, not just waiting for bad things to happen, but the whole concept of development of varying degrees of heart failure in our patients really relates to figuring out what those early triggers might be that patients could feel even better, live even longer, be more successful with those interventions in a timely fashion.
And kind of talking about the lack of evidence and the small trials, the heterogeneous anatomy that we see in this patient population, if you look ahead towards the next decade, how do you envision multi-center collaborations, precision medicine, artificial intelligence kind of helping us to reshape the evidence that we have to be able to provide, optimal care for our patients in the next decade?
I'm pretty optimistic about the next decade. I think that we are training a generation of people who are much better with some of the artificial intelligence type systems than I was certainly trained in. And it's exciting. But I think we do need to have a little bit of caution about how we roll that out. And I think that there are times when even the best AI models don't always apply to the heterogeneous anatomy and conditions that we see. But it's in that training process where, with the right amount of input and personalized data that we can provide, and then looking at what do those models do well, and where do we need to pivot and work more closely together. And I think multi-center collaboration over the past decade already has come such a long way, and that now we have so many centers that are able to work with each other to get the number of patients that we need to power studies to actually show something that may be statistically significant in a powerful way is already happened, and I think that's only going to expand in the next decade.
And just to call out, the guideline itself really lists kind of multiple broad future directions, specifically, more or increased neurocognitive screening, mental health screening, genetic screening, AIECG, all of those are referenced in the guideline. Do you think that there's one that we've kind of already demonstrated quite a bit of success or is kind of closest to real world implementation, in the next 3 to 5 years?
I'd like to think there's several, but I think there's always room to expand. I think that our ability to work with patients and understand more of the genetics has come a long way, especially in the area of aortopathies. Now we're able to target certain types of genetic malformations to therapies, and that's very exciting, or also help with that risk prediction just based on the genetics. And I think that that's something that, again, we're going to continue to work on. There's so much more possible. And a lot of that does come down to now with some of the artificial intelligence systems that have been built and are being built, how can we best align ourselves to use that data successfully to think about what outcomes are we actually trying to look at that are important? It's not always mortality, and having patient-reported outcomes front and center to a lot of the decisions that we're making are going to be really important. I think that thinking about timing of interventions is the other future direction that I personally would really like to see move forward, using evidence about timing of when to do something, when to put in a valve, when to put in an ICD, when not to. Thinking again that these decisions are based much more on an entire lifetime of risk in comparison to many adults who experience cardiac disease for the first time, and it's a defined time of risk, the highest risk being around the time of the procedure. But people that live with congenital heart disease, they don't have that type of risk assessment. Their risk starts when they're born. They have high risk when they're first intervened on. And then there's varying periods of risk. Some of those relate to certain hormonal changes, such as in pregnancy. Many people have a higher risk. The issues of aging and other factors that come into play. So there's a lot of work still to do.
And finally, I want to touch on one more patient population that was kind of very explicitly called out in the ACHD guidelines. And certainly, as we've been talking about evidence to be able to support care, this is a population that has been historically kind of limited from clinical trials, but has received a lot of attention recently. And that's the Fontan population. We obviously know that they face long-term risks of multi-organ dysfunction, particularly liver disease. How do you think ACHD programs should kind of rethink long-term surveillance and multidisciplinary care for this growing population?
It's amazing how much more we know about the Fontan than we did for the last guidelines. If you look at the number of recommendations that are there, but it is complex, and I think it takes a village, and the Fontan population is a perfect example of that. It really is something that we have to think about as a multi-system disorder, and we have to start thinking about it well before they get to the adult congenital heart disease clinic. And I think we know that there's evidence that shows that those liver changes that occur happen very early in life after the Fontan. And so again, it's a great example of success when there's partnership between the various specialties to be able to work with patients to learn more about what the potentials are of living with a Fontan. Are certain medications that are used for two ventricle hearts going to be successful in the single ventricle? Should we be thinking about different types of devices, or maybe even different types of exercise strategies? It's not just the medications that we think about long-term with patients with Fontan, but it's other things like how could you incorporate exercise, even lower extremity resistance exercise or certain respiratory exercises. And we're learning that there's a lot of physiology that could be targeted through non-pharmacologic methods as well. And then when you do get patients that have more of the Fontan physiology phenotype that is failing, those triggers to say, now it is time to think about advanced therapies, transplant, the complex issues of the transplant being not just heart, but often heart and liver, and how can we best position people for success when they're starting to go down a road that they're not doing as well with Fontan.
Thank you, Anne-Marie. This was an excellent discussion, and I appreciate your insights here. Are there other things that you'd want to bring up kind of about the guidelines that you think others should know?
So I have a question for you as an executive associate editor of JACC. As you look at these guidelines, where do you see opportunities that we as a field can take and move forward, looking at how can we best get the evidence we need and the publications out there to make a difference in the world of adult congenital heart disease?
That's an excellent question, and one that I think not only plagues, adult congenital heart disease, but also pediatric cardiology. A lot of the concepts are universal across our fields: small sample sizes, heterogeneity in patient anatomy, patient physiology. And so how do we try to kind of leverage the observations that we're getting at our collective centers to be able to move the science forward? I really see kind of three areas that we can really be building on. One is we need more novel methods. I think we recognize that our patients are never going to receive nearly as many clinical trials as the adult cardiologists do in their populations. And so we need to start thinking about how we leverage the multi-center collaborations we have in order to be able to think out of the box and come to the same determinations. Leveraging causal inference techniques is a prime example of where I think our field needs to head. The other thing is we need to start thinking about more novel clinical endpoints. You touched on a number of these today: mental health conditions, neurocognitive outcomes, but starting to think about not only the traditional outcomes of mortality and transplantation, but what does it really mean for patients who are living with this long term, and how do we start to really kind of take this back to the patient experience? And then finally, novel angles. There are so many very interesting methods that are coming out, kind of novel perspectives, AIECG, omics, the genetic component here, kind of taking novel angles to questions that we've asked previously, but start to kind of let us dive a little bit deeper. I think those are the types of manuscripts that we need. Those are the types of studies we need to start to move our field forward, and will really help us kind of enter the next decade.
Agreed. Let's do it.